weekly contributor meeting. Thank you all for taking the time to join us today as we continue to collaborate and advance our shared goal. Today we have a packed agenda. We'll have our regular leadership update, and then we'll have our program coordinator, Nadia, to talk about the PACIO engagement efforts, which is including turn on your camera if you can during our meeting. Then we'll have Uba to share the upcoming conference opportunity with the community. With that, and we'll follow with the subgroup updates. Lastly, we'll have Maria to talk about submit the comments for the CMS RFI. We'll also cover, if we time, we'll have the time for the walk-on topics. Without further ado, I will pass it to Dave for the leadership updates.
All right. Thank you, Yolanda. Let's see. Let's bring it up. All right. So PACIO use cases, not much change on the timelines. The gray line continues to march to the right. We are in preparation for getting ready for ballot for STU2 of advanced directives for the September ballot. I've got some things to still iron out there. Then we have personal functioning engagement, STU2, and that is in the publication process. And then that's for STU2, and then for transitions of care STU1, ballot completed yesterday, and so we are going to start looking through those ballot comments and start ballot reconciliation. So lots of things going on. Upcoming conferences, we have the EMEA conference, May 20th to 22nd, so that's coming up close quickly. Many thanks to those who are participating and representing PACIO on that. There's the HL7 WEDI person-centered care for healthier communities. We're still working on what the presentation topic is there in alignment with what they're looking to present. We hope to have that ironed out very shortly. The CMS Connect-a-thon is July 15th to 17th. There is free registration that will be open from May 13th to June 30th. And we will be continuing the Connect-a-thon planning activity tomorrow during our tech team call from 10 to 11 o'clock Eastern time. So if you are interested in participating, attending on the behalf, to see what PACIO is up to, I encourage you to come to that call. And then the American Health Information Management Association annual conference in Minneapolis. We've submitted an abstract. That's October 12th to 14th. And then we've also submitted an abstract to the National Committee for Quality Assurance Health Innovation Summit in San Diego. And I think that one has been accepted. On value-based payment transitions of care in the PACIO project. So those are very, overlap. And again, we are very appreciative of the PACIO community to help us get the word out on on all the great work that's happening here. Just a few words on the Connect-a-thon planning for CMS. It's really a great opportunity to demonstrate to CMS our progress and what we're doing. We've submitted our track proposals. You can see the links there. And what we will be working on really over the next couple of weeks is to really nail down the story. We're looking to sort of align both of these tracks to the same story. And so we'll be working on the story sort of as a one entity, and then we'll be splitting it up, the key pieces of it amongst the tracks. So that's the current theory. And we're really hoping to nail that down in the next couple of weeks. And then, so the PACIO Tech Team call is where a lot of that's going to be happening. We are doing some of that also during our individual use case calls, and we've been doing that this week as well. And May Terry did a great presentation last week on creating sample data. This week we'll be focusing on really nailing down the story. And if you're interested in participating, as I mentioned, please attend this meeting. It really helps determine what can be possible, who's going to be able to participate, and we need everybody's feedback in order to have a really good story. So very much appreciate that. So the timeline overall for the Connectathon planning, where as I mentioned, we're looking to really finish up the scenario in the next couple of weeks. So basically a week from tomorrow. Two more tech team calls to try to air that out. So that's May 15th. Then we want to try to get the sample data a complete draft, and again a draft form, June 5th, 2025. Then sample data frozen on June 19th. We want to do a demo dry run on June 26th. That's where we run through both of the scenarios to see or the scenario on both tracks to make sure that things are moving along there. We want to do a second dry run on July 10th, right before the Connectathon, and that's really kind of the last opportunity we're going to have to do that. That's those are during the tech team calls, and then the Connectathon testing and demo. It's a 3-day event, the 15th through the 17th, but the testing and the demonstration part of it will be July 16th. And so that's kind of the timeline. And we're doing the tracks separately each 4 hours. So we're not going to have a lot of time to do testing at the actual Connectathon. So, and this is, we typically do this anyway. We want to make sure that we get all of the various issues ironed out before we get to the Connectathon so that hopefully we're just fine-tuning things when we get there. We'll only have about an hour for each track to really test things. So it's about enough time to make sure that all of the connections are working and all of that sort of ready to do the demo. So we won't have a lot of extra time. Any questions on the Connectathon or concerns, recommendations? All right, then with that, I will hand it back to Yolanda.
Thank you very much, Dave, for providing the updates. And just trying to want to add the HEMIAS conference, the PACIO abstract is accepted, and Jamar will be presenting on behalf of PACIO.
Yep. Great.
All right. And next, I would pass it to Nadia to talk about the PACIO engagement efforts.
Hello. So thank you for all being on camera. I'm glad you read the email, got the memo, and are deciding to participate. It's great to see your faces and having your voices linked to your faces. I think, we decided to implement this because we think that it's going to make our PASIO meetings much more engaging. It's really going to kind of help us feel like more of a team and more of a community as we call ourselves. But it's really just to make us really feel like we're all in this together, to hold us accountable to the work that matters for all of us nationally. And I know that, many of us are here on a volunteer basis, and so we so appreciate your time and we so appreciate your expertise and everything that you're willing to share and put forth in this initiative. And so, that being said, we're so happy you're here, and we're so happy we get to see your faces and hopefully have everyone participate more. And as much as you're comfortable. That being said, also, if you're eating lunch, that's cool. If your dog barks, that's fine. And we understand that, eyes are going across the screen, and we're all making the most of our time and still listening. And so we just appreciate that you're here, and we hope to keep seeing you here on camera. The other efforts that we're going through, we're going to be trying to establish more of an active presence on social media for the PASIO project. Our first step is going to be to start posting and actively searching to expand the LinkedIn group that we have for PASIO. I think we're going to be looking into some other methods too and see what lands, maybe a Blue Sky account, maybe a Slack channel. But ultimately, we again really just want to make this feel like a community and have our word out there about what we're doing. And so I'm going to be pursuing finding different provider groups and relevant stakeholders that might be able to provide more insight as well on these social media platforms. We're going to be prioritizing taking pictures at events when we travel and when we have our lovely community members in the interim and going forward, presenting on MITRE's behalf. We want pictures of the team, we want pictures of the posters we're doing, and really get our word out there just in general. I think, there's a lot of changes and uncertainty in the world. I think people are really feeling protective of their roles in their organizations, and this is volunteer basis work for many of us, but it's really important work. And so we want to get that as far reaching as we can. And I think that's about where we're at. And we'll keep you updated along the way.
Thank you very much, Nadia. I think that the goal is trying to make the PACIO meeting and the community more engaging, more interactive. And we are also open for any suggestion and the comments and any ideas you want to share with the community. All right, next I will have Wuba to share the upcoming conference opportunities.
Excuse me. Thank you, Yolanda. So I'm going to share a few conference opportunities. Let me maximize this here. Okay, so can everyone see my screen?
Yes.
Okay, awesome. So we've identified several conferences where PACIO can submit work. And unfortunately, because of travel restrictions, where these opportunities, unfortunately, typically MITRE folks would be presenting at these, but we can't come to these opportunities that are coming up. So in order to submit future conference opportunities, there needs to be a PACIO community member on the author list who can be at the conference and present at the conference. And they need to be able to not only travel to the conference, but cover registration if that registration is required for the presenter. It's not required for all conferences. The Health Information Association meeting that got accepted for October has waived fees for presenters, so that's absolutely wonderful. So it's not a given for every conference that the presenter would need to pay for the registration. The community member wouldn't be on the hook for doing all the work to get the submission together. I will still be involved in drafting the submission, creating whatever media is needed. If it's a poster, I would work on that. If it's a talk, I would work on the slide deck with the co-authors. So and would be leading that work, so you wouldn't have to worry about the heavy lifting on that. So that's the situation we're in right now for conference submissions. And the next slides have some opportunities that are coming up that have due dates soon. So there's first the Healthcare Compliance Association's Compliance and Post-Acute Care Conference. It's in December and it's virtual. So this is a great opportunity because you don't have to worry about paying for travel. They have a presentation type where you can give a talk. And this is a new conference. So it's exciting this opportunity is exciting because we can be on the ground floor for kind of setting the stage and getting the word out amongst the attendees. And this conference is for compliance professionals across the post-acute care spectrum and designed for those working in skilled nursing facilities, home health care, long-term acute care, and hospice, and event delivers focused on education and navigating complex regulations and strengthening compliance programs. So this is an audience that's very much aligned with PACIO and would be a great audience to talk to. Because this is a new conference and we've never, obviously never spoken at this conference before, a potential topic could be, what is PACIO and its impact that it could have on PAC settings. And we already have a lot of great material that we could draw from to easily put a submission together for this relatively quickly. So what I'll do is after I finish this slide and the next one, I'll put links for the different conferences, for these conferences in the chat. And then you can get in touch with me if you're interested in collaborating. And then the second conference opportunity is the American Physical Therapy Association's combined sections meeting in February. It'll be in Anaheim, perfect time of year to go take a trip down to California, especially if you're in the cold climates. The deadline is on July 15th, and you can either submit a poster or a presentation. This is a pretty big conference. There's 15,000 physical therapists, physical therapist assistants, educators, researchers, students, and industry professionals who come to this. And it's the APTA is the professional organization for physical therapists. And so this would be another great opportunity. PACIO hasn't been to this conference. And so again, we can give like a PACIO basics and talk, and especially if we can give a presentation, talk and show some videos of some demos from a Connect-a-thon to show the power of PACIO. So this would also be a good opportunity to recruit folks to also participate in the project. So I just as a FYI, we have an active list of conference opportunities, so I'll be coming back to you all with more opportunities. You can also send me opportunities that you come across that might be good for PACIO to present at. And then also get in touch with me if you end up attending anything or knowing of any conferences that PACIO could be involved in, and if you're interested. So I'll put the links for these conferences in the chat and my email as well, so you can get in touch with me. So that's it for me, and I'll pass it back.
Thank you very much, Wuba. And since the communication pass and the travel pass, and I think we are really appreciate the community step in to help their present their PACIO to the outside world. And the community has attended NAP, AOTA, and Point Click Care Summit conference, and their community member came back to the community report what they learned. And we, as a community, we learned from this opportunity, and it helped us drive the future direction of this project. So feel free to reach out to Uba if you are interested in join the upcoming opportunities, or you learn additional opportunities, and let us, the rest of the community, know. All right. Next, we will have our subgroup lead to provide their updates. And first, I will ask Jamar to provide the PFE subgroup updates.
All right, thank you, Yolanda, and hello, everyone. So we did have a PFE meeting today, and we took a detour from looking at the device profiles and looked at the CMS Connect-a-thon and the scenario activity. So we are reusing some of the, or reusing Betsy Smith Johnson overall, and also some of the scenario that we used with her in the past. So the team today looked at how are we going to make this scenario realistic, as well as reducing burden for us and the MITRE staff and technical staff as well. So that's when I talk about reusing some of the information, we really do want to make sure that we reduce burden. But we're looking at her having a stroke, and not necessarily another stroke, but kind of going back in general, and what deficits is she going to have from this stroke? And in specific, what deficits are going to lead to an ED visit, to the SNF, home health, and PCP? So lots of conversation there about how is she going to look clinically? How are we going to make this representative and realistic? But also, how do we integrate PFE services in each phase? And what does that look like? What would constitute needing physical, occupational, speech language pathology in these settings and for these scenarios? Some other things that we talked about was caregiver burden. So that's something new for us that we will be implementing in this scenario activity in the recent Connect-a-thon. And just looking at other areas that have not been addressed in recent Connect-a-thons from a PFE standpoint. So that was the majority of the meeting today. Next meeting, if we don't have anything to do with the scenario activity anymore, so if there are no more refinements to that, we will go back to the device definition profile. So continue our work there. And in the background, the leadership team is going to be looking at examples of device coding and looking at what coding system to use and making sure they're sufficient. So in specific, we'll be looking at SNOMED, the International Classification of Health Interventions, which is published by the World Health Organization, and HCPS for just devices. And that is all. Any questions? I'm happy to answer them. And thank you to all the PFE members who are on the call today. I know I see Leanne and Roberta and Joanne here. So thank you all.
Yeah, the only thing I'd add is PFE is in review for publication by the Patient Care Work Group, and so um, they are on their way, this later this week to Spain for the work group meeting and the Connectathon there. Um, that's next week or this weekend and the following week, and then we hope to follow up with them once they return to move that along. And so after patient care, then we go to fire management group, and then finally to the technical steering committee, who has the final approval before it's published. So,
Thanks, Dave.
All right. Thank you very much, Jamar and Dave, for providing the PFP subgroups updates. And I think today's discussion helped a lot to create a storyline for the Connect Zone, and we'll bring that consolidated with the ADI track leads and to unify the scenario and to meet the need for both of the tracks. So next up, we have a TOC update, and both James and Terry are out of office. And Dave, could you help provide the TOC subgroup
yeah.
update?
Yeah, so the TOC has been in ballot. Ballot closed yesterday. And so we have 22 affirmative votes and 2 negative votes. So we passed. The threshold is a 60% affirmative. We are more like 91% affirmative. So yeah, so that's good. So there are a few comments that we're going to have to go through. I think there were 8 or 9 that we're going to have to go through and look at. And there's one in particular that I think, it may take a little bit of time for us to work through. But otherwise, I'm hoping that it will be a fairly quick reconciliation, and then we can move to going to publication approval. But that's, it's going to probably take a few months to do that. So that's what we're working towards. In the meantime, we're actively looking for behavioral health and further work there, as well as patient advocates, whether they're patients or whether they're caregivers. We want to try to get their input on to what information is critical for them. And depending on how quickly we can do that, we might be able to include some of that stuff for testing in the CMS Connectathon. We'll see. But that, it'd be really cool to be able to test some of that stuff. But if you know folks that might be very interested in this, in those 2 areas, we would love to have them spend probably a few months with ideally a few months, 2, 3, 4 months, to be able to go through that and work through those items. So again, this is to add their perspective to the Dell data element library items as well as non-Dell items, so that as we try to put together a minimum data set as to what is really necessary for transitions of care. So that's the goal. And so I think right now those things that if those 2 areas, as we work on those, I would like probably there's a possibility we might be able to squeeze it into STU1, but more likely they're probably STU2 items since we have gone through ballot. Any questions? All right. I will hand it back to Yolanda. Thank you.
Thank you, Dave, for providing the TUC subgroup update. Next, I will invite Maria to provide the ADI subgroup updates.
Okay, I'll turn my camera on for a minute. Let me see. Make sure I'm sharing the right information. All right. Can anybody not see the ADI subgroup report out? Okay. Well, as you would imagine, we just wrapped up a meeting, so we had to hurry up and get our notes together. On the leadership updates, we did give the community the notice that the tickets contained in block vote 2 were voted and approved on May 1st, last Thursday's meeting. And so those tickets are all approved. Patient empowerment went through, and we got an 8-0-0 vote. And we are now turning the corner and beginning work on block vote 3. From a governance perspective, one of the things that we have run into, and you guys might run into this on a couple of your projects, patient empowerment is our primary sponsor. And so there are times when we have taken block votes to patient empowerment. And because that community is broad and focuses on many things that are happening in HL7 and in the healthcare ecosystem and how patients can be represented in that work, they aren't always intimately updated on the work that ADI does. Sometimes we have gone to take a vote and enough people have abstained because they just don't have enough detailed knowledge that we almost haven't been able to proceed with the vote. And that's not the purpose of the vote. So we did get some guidance from somebody on the HL7 board who referred us to, we love our acronyms, to the GOM, the HL7 Governance and Operations Manual. And there is a process that many, many projects have adopted. And that is a quorum style block vote that occurs within the community. And so if we were to do a block vote and solicit approval, there are rules of engagement. So for example, one of the co-chairs from the primary sponsor work group has to be on that call. And I'm one of the patient empowerment co-chairs, and I am one of the leads on the ADI community project. So I'm always involved. In addition, there has to be at least 2 people who are a part of that primary work group sponsor. And very, very often we have at least 2 people in the ADI community who also attend patient empowerment regularly and are part of that community. When we have met that criteria, we are able to present the block vote. What was the issue? What is our proposed resolution? Answer any questions that we need to answer. And of course, the ADI community is very, very close to this subject matter. And so they will tell us the what. We will go out and figure out the how. We will talk about the how, where we got the idea from, what it means, how it would look. And then we typically do that before we even come to the PACIO community and solicit your approval. So we won't have to go into patient empowerment any longer, which tends to really delay the entire process. And, speed is everything. I will report to patient empowerment when a block vote has been introduced. I will report off to them the results of the vote within the ADI community. And we will certainly make sure that the ADI community meeting minutes from those block vote sessions are also posted on the patient empowerment site. So there's a few boxes that we have to tick, but we're in really good shape. We did not pick up any objections. Everybody wants us to hurry up and get done so that we can, move to mental health directives, and they're going to want us to hurry up and get done. And so removing some of the delays due to a perfectly normal, widely observed way of achieving quorum, there was no pushback at all from the community. We did remind them, and it's sort of like when you get up, okay, I have a 7 a.m. flight. Let me work backwards to what time I need to wake up that morning. We did look at the notice of intent to file our ballot, the July CMS Connectathon, and we started working backwards. And so around mid-June, our team is going to be halting to the greatest extent possible technical changes on the ADI with FHIR IG STU2. Now, if you can sort of pull a code freeze, and that's not to say we won't continue to refine narratives. We won't make our diagrams better. We won't make our crosswalk between CDA and FHIR via a table better. There's a lot of work that we still need to do. But if you can freeze those technical changes to the greatest extent possible, you can draw more participants to the table who will say, well, I'd love to participate. I just need to see the IG. Like, how high is the bar? And so we're going to look about mid-June to hold that rascal still from a technical perspective. And then once we file our NIB on June 29th, then that will ready the HL7 community for us to go to ballot in September. On a related thread, the ADI team is going to be participating in the CMS July Connectathon. And because we will have, really stilled the IG technically in preparation for the CMS Connectathon, it's really going to put us in good shape for freezing off the IG officially. All the edits are done, all the narratives are done, you've corrected your typos, all of that good stuff to go to ballot in September. So those last two items are actually related because you almost have to count backwards to figure out how do I get two things done in very close proximity to each other. When we had the actual subgroup, the actual community meeting, we did a lot of different things. I covered just a few of the last open items on the environmental scan. And we talked about some VSAC value sets that we have reviewed and that we have vetted and that we're going to be referencing in the IG. We also talked about provenance. So on portable medical orders, signatures are a big deal in the world of humans. It's an order or it's an order panel, so it needs signed. And so we really talked about, now hold on, what does the provenance resource do? Doesn't it, really establish immutability of that particular document or order? How can we leverage provenance? You've got your composition, which is sort of your table of contents. You have your completion information section, which is where the signatures reside. What do you do with provenance to say, well, from here to here to here is what you need? And so we really took a lot of time to sort of talk through that. In the completion information section, and remember, there's really two things that we accomplish with this version of the IG. We are requiring that a human readable version be sent along with the data. We have to build an on-ramp for people to move from the paper that they've always known, even if it's a scanned paper in their EHR, to digital data exchange that has meaning and depth and substance. And so we are requiring that there be, a PDF or a human readable version. And when we're talking about some of this work, provenance, completion information, et cetera, it's really easy to represent on paper. We've been doing it for decades. But when you think through the hoops that you need to jump through to build machine-to-machine communication that is semantically correct and accurate, it gets a little bit harder. So, signatures are going to be included in the machine level packet in the completion information. Referenced by provenance, included in the composition header. We've got all the pointers where they need to be. On the human readable form, signatures will be where they've always been. Date form prepared. We talked about this a little bit. So imagine, if you will, that I had a consultation with my clinician on May 1st. And so the healthcare provider who is assisting with completion of the form is going to sign the form on May 1st. I might sign the form on May 1st. And then my practitioner comes in. My practitioner is a PA, and I'm in a state where a PA requires supervisory oversight. And so the PA comes in on May 6th and says, yep, I've had the discussion with the individual. They understand what they did. They've got the risks and benefits. I'm going to sign this form. That form is actually not complete in a state that requires this until the supervising physician has also co-signed that form. And there are provisions for that in the majority of portable medical orders. And so we're like, well, when do you mark it complete? And then you've got this date form prepared. Well, maybe I prepared it and I got 2 signatures on May 1st. And then the physician did their job and they signed it on May 6th. Oh, but the supervising physician didn't sign it until May 7th. Like, who comes first? So we had a lot of discussion about that. Raj was phenomenal. He took me to a very high level, which is where I was, and talked about the rules and, the training periods and all of that good stuff. And then Dr. Abby Dotson took us back and said, you know what, that is correct. But for a portable medical order, here's how it works. And so we're going to need to figure out how to give some instruction in the implementation guide. If you are in a state where a PA signing off on the form is legit, but in that state or jurisdiction, you need a supervisory MD or DO signature, we're going to have to provide some guidance in the IG. We don't talk about business process in technical implementation guides, but we will bring out the nuance and probably just recommend some websites or some references that an implementer could look at to understand how they might build their platform to work. So that kind of wrapped up the date form prepared and the signing provider. So I know there was a lot of stuff. Does anybody have any questions, or is anybody on the phone dealt with PAs or NPs and supervising MDs and you'd like to add to the discussion? Because we're sponges. We will take in anything that you share with us and we'll go research it and we'll come back to you and let you know what we learned. So if you guys have thoughts, bring them. So you never get to see this when I'm not on camera. All right. Yolanda, I think I dazzled him.
One other thing I'd add, one other thing I'd add is that, I think it's a credit to the community and the reputation that we've been able to build with HL7 work groups to allow them to give us to approve of the ability to review and decide things in our own communities. I think that's a huge step. And speaks to all of the great work that's been going on here to everybody. So really, really appreciate everything that people have done here. We are making a dent in the universe. So
We are.
we'll make it
We are indeed.
easier. So
No, I love that. I've had discussions recently with ONC. I refuse to call them ASTP. You cannot move my cheese. With the ONC and with CMS. And they have been so keenly following the ADI work. It is really important to people and really very aligned with the current administration's goals to eliminate fraud, waste, and abuse, and to improve end-of-life care and to focus on quality in nursing homes. So, we've had a lot of discussions, and this project is being watched and it's being supported. So, I want to thank MITRE for their support and really making sure that all the work that PACIO does is elevated. We could be working in a vacuum like long-term care always has, doing good work, making good grades, and then nobody would know about it that needs to know about it. So in reverse, I commend the MITRE group and in all of the evangelization that they have done of the work we do. Dave, one of Patient Empowerment's projects was patient request for corrections. I don't know if y'all ever knew that.
Yep.
But if you ever, got access to your records, and I'll take an extreme case because that's me, and somebody put my weight in as 118 pounds because they fat fingered it and it's 181 and it's not 181, but I'm just saying it should have been 181 and through human error, they put the wrong weight in there. That affects medication dosage. That affects so much of my healthcare. And this project run by Virginia Lorenzi created a formal communication protocol between the provider, probably the HIM department, and the individual who's like, ooh, okay, that's not right. Patient request for corrections. And Virginia would just bring the results of these changes to the IG to the patient empowerment meeting. And I thought, Well, God, why weren't we involved in that? I want to know what's going on with that. And when I asked Virginia about it, she said, we follow the quorum process and we know our subjects and we have really good people on the call. And I review them with patient empowerment. And if y'all have questions, ask them, we'll re-up in the ticket. But we don't really slow your roll that much. And patient empowerment doesn't have a lot of FHIR experts. And we're patients. We don't always know how things happen in clinical practice. That's why we're at the table. So we're modeling what another group did. And when I took it to not TSC, but the board, they're like, yeah, where you been? Of course you can do that. So we're actually modeling a working process too, just in case anybody's wondered.
Yeah. And well, thank you for your leadership, Maria. Appreciate it.
Yeah, I think that's wonderful. And many of the PACIO use cases touch of our not only our professional life and our personal life, and everyone need to go through those journey, and the patient and providers, and eventually we are all patients, right? So this is great, the work we are doing. Thank you, Maria, for providing the ADI subgroup update.
My
All
pleasure.
right. Yeah, the last topic on our agenda is about the CMS RFI. Maria, I will pass it over to you.
And here's what I'm going to do. I'm going to put the link in the meeting chat. And for those of you that heard me last week, I'm going to ask for your forgiveness and your patience. The PACIO community flexes just a little bit, just like the ADI and the patient empowerment community does, right? This is a non-paid position, so we come as often as we can. I raised some awareness last week, and it's really neat since then, and I don't think it's anything I had to say. I've gotten made aware from a couple of LTPAC vendors that they are also organizing users to review this opportunity and weigh in on it. I wanted to create awareness. We're not organizing a PACIO response because it's, I don't know my good words. It's weird for the PACIO project to be supported by CMS because they believe so fully in what we do. And then for us to organize an effort to maybe tell them where things need to be streamlined, or we can reduce some administrative burden, or we can call out some duplicate requirements. It's just not the right tone. We appreciate their support. We don't need to go poking holes in things from a PACIO perspective. But I wanted to raise this for your awareness yet again. And a couple of vendors, like I said, like it was like the day after we had the last PACIO call, and I got it invited to this, community thing that they're ginning up. So please go back to your organizations. I believe that they are truly sincere and extremely well-intentioned. They know that CMS is a big mamma jamma. They know that there's DME and there's Part B and there's hospice and there's Part D drugs and then there's LT-PAC and then there's, all of these threads that spin into this world that we live in and we have lived in for so many decades. They know that there's times when the claims people need one thing, but the clinical people need something else, and they might not be talking fully or comparing notes. So we have an opportunity through an RFI request for information in support of, trying to lighten the load that the Medicare program places on all of us. And again, it's not that it's not appropriate. You better be crossing your T's and dotting your I's when you're dealing with Medicare patients. But for them to say, would you please tell us where we've got regulatory requirements that are heavy, that it just doesn't make any sense to you? Like, where are you doing one thing one way for CMS request and it's a quality or it's a claim issue or it's a some other issue, and then you're turning around and you're just doing something very similar for another part of CMS. Like, help us help you. So I really encourage you guys. I mean, I drowned in it for years when I was working in the buildings, running the business office, running IT for Brookdale. I mean, we had reporting coming out of our ears, and not all of it lined up. And some of it was, boy, howdy, was it close. It was as close to redundant as it could be, except there was just a nuance that was off. You guys, this is our chance. Where can we identify for them that there are some regulatory requirements that really we could streamline? Or where could we reduce our administrative burden? You know, where do we have people pulling numbers and statistics and we're getting it, I'm just making this up. We're going through all the MDSs and we're counting hash marks. Why can't you? If we're going to the MDSs to pull this, well, you guys have already got the MDS data. Can you pull it? Or we don't like your template, but we could run a report and we could dump the data. Is there any way you would take a data dump as long as it was identified versus us dumping the data and then handwriting it on a form? There's so many little places. Duplicative requirements. Sometimes we don't know what's duplicative until we ask our buildings stem to stern. Just like Medicare might not know. They might not know that there's a DME requirement, that the business office is also substantiating on claims, that the nursing department is also substantiating in terms of special services and equipment. So let's tell them. And then they gave us a softball and they said, any other suggestions for deregulating, or if not that, reducing the burden on providers and suppliers that participate? Now, they've given you some guide rails. You just can't fuss at them. They would like to know where we can. What's the data that falls into these categories? Can you give me an example? You know me and my examples, because I'm not a theoretical girl. I'm a tangible girl. What are some narrative anecdotes? Yeah, we get PDFs in every Friday afternoon at 4 o'clock when the hospitals are clearing beds. And these PDFs are 250 pages long. Meanwhile, I'm admitting 4 new patients and I'm already cut to the bone on staffing to be at the regulatory levels. Like narrative anecdotes and then recommended actions. It's just fussing until you give them some ideas of what might work better. And you're talking from you. What might work better for a provider? Because you don't know what's going to work better for CMS. So I just wanted to encourage us to take advantage of this opportunity. The opportunity to share feedback isn't always available to us as a population. And there they are with a full-blown RFI for long-term post-acute care saying, help us help you. But we don't know, because if we knew, it probably wouldn't still be there. So tell us what we need to know to lighten your load and to work smart, not hard. And I just want to encourage everybody to do that. I am 44 years now, and I don't weigh 181 pounds, working in long-term post-acute care. And I love this industry, and what we do is vitally important. But we're packing a load. And now is our chance to stand up and just say, look, I'm doing this 3 times, or I'm doing this once, or what are you even collecting this for? Because I've never seen anything happen from it. Please speak up and be heard. Thank you.
Yes, thank you, Maria. I think the deadline to submit the public comments is June 11th. That's for the public comments period ends. Feel free to submit any comments for those RFI. All right. We cover a lot today, and are there any walk-on topics from anybody?
I have one walk-on topic if we have time.
Sure, Sarah, go ahead.
Okay. All right. Hi, everyone. I'm Sarah. Like Nadia said, it's nice to see everyone's faces and connect with names and voices. So hi. I usually work with Michelle Galeato, who's not here today. We both work to support HIT Work Group, which some of you are familiar with. Just for context, that group, we really work to identify both barriers and opportunities across LTPAC and the broader healthcare landscape to really drive progress and interoperability with a focus on the post-acute care space. We've spent a bulk of our time really trying to identify challenges, which I know like a lot of we are familiar with, fragmented workflows, finance barriers, limited infrastructure, all that fun stuff. But we really want to shift our focus towards solutions. Specifically, like we're really eager to spotlight real world success stories that demonstrate effective, scalable data exchange across different health systems and different care settings. So given this group's involvement in IG development, we really think that you're uniquely positioned to help us maybe identify early adopters or any organizations that have like successfully implemented interoperability solutions or workarounds in spaces. So basically my question is, do any of you know of any provider organizations, LTPAC vendors, initiatives that have really created tangible success with data exchange across those different settings or health systems? And if so, would you be open to sharing that story in a different setting? So I know that's a lot for today, but I'll just drop our email in the chat. We'd really like to hear from you. And as PACIO knows, like demonstrating success, and as this group does often, like connecting with other vendors really just helps them move the needle forward from theory to practice. So that's really what we want to try and do. So yeah, I'll throw that email in the chat, and please reach out if you have any ideas or know anyone that we should reach out to. That'd be awesome. So thanks.
Thank you very much, Sarah, for sharing the information of the HIT work group. And definitely the adoption about the standard is our goal as well as a PACIO project. And anybody, if you have any vendor or provider who are interested in implement the IGs, feel free to reach out to the group. Great.
Thanks, Maria.
Yep. All right. Anything else? Any other walk-on topics? Great. Thank you, everyone, for your valuable contribution and insights during today's discussion. It's so nice to see you, so many friendly faces and today, and we cover a lot. Special thanks for the presenters to share the updates and driving those important discussions. And moving forward, we really value your inputs to shape out the future work of our program. If you do have any follow-up questions or need additional information, don't hesitate to reach out. And we look forward to see you at our next meeting. And have a great rest of your day. Thank you, everyone.
Yeah, and I put a link to the YouTube demos in the chat. So grab it
Cool.
before we close the meeting.
Fun. Thank you.
Thanks so much.
All right.
Thank you.
Thank you.
Take care. Bye-bye.